Good afternoon. My name is Laura Adams, and I'm the chair of the National eHealth Collaborative Board of Directors. Thank you very much for joining us in our meeting today. We're absolutely delighted to have so many people participating online, and thank you to those of you that are here with us in the room today. As always, we welcome your questions and comments via the webinar or at email at info@nationalehealth.org, or our staff is monitoring Twitter hashtag NeHC. For those of you that are able to join us in person, printed copies of the agenda and the presentation slides are available just outside the room. For those of you online, the packet can be downloaded from the NeHC website at www.nationalehealth.org, and it's available now. That's www.nationalehealth.org. We're asking that everyone participating online submit your questions and comments for today's stakeholder forum in writing. But we will also have a public comment period at the end of this session in which I'll individually unmute phone lines and you can share any comments with us. If you'd like to speak, please make sure that you're logged into the webinar and you've used the webinar-generated attendee ID when you called in on the phone. I'm more than excited about our stakeholder forum today, so I'd like to get started by calling this meeting of the National eHealth Collaborative Board of Directors to order. I'd like to ask for if there are any conflict of interest disclosures that need to be made at this time. Seeing none, we'll proceed. Today's stakeholder forum is one that I find especially exciting and well, meaningful, actually. We're very pleased to have Dr. Martin Harris of the NeHC Board, also Chief Information Officer and Chairman at the Cleveland Clinic. Delighted to have him today to moderate a discussion on the ways to bring about health IT innovation using an opportunity presented to us in the Meaningful Use Incentive Programs as a catalyst for change. This topic, I know, is on foremost in most people's minds that are dealing with health information technology, and it is just, we think, replete with opportunities, many of which we'll hear unfold today in the stakeholder forum. So I'd like to begin by asking Dr. Harris to introduce our guest.
So thank you very much, Laura, and I too am really excited about the conversation we're about to have this afternoon, and our guests have chosen to make their presentations relatively short so that we do have opportunity for interaction with the group that's present and online. I think to get through this quickly, I'm just going to introduce the individuals and give them a chance to say a word or two about themselves and their organization as they go forward. But we do have Keith Michael with us from Manchester, Vermont, and he's a practicing geriatrician and internist. Jeff Blair, who's the Director of Health Informatics of Lovelace Clinic, and Eva Powell, who's the Director of HIT Programs for the National Partnership for Women and Families and Consumer Partnership for eHealth. So I'd like to thank all of our speakers that are here today, and I'd really like to move on to the primary presentation. So as Laura said, what we want to do today is not focus on meaningful use per se, but to think about how we can take advantage of the fact that the nation is going to move to meaningful use, to really to think beyond that and focus in on the transformation of the healthcare delivery system as we move forward. So with that, what I thought I would do is walk you through, if I can aim this the right way. So that's not going to work. Okay. So I'm going to walk you through a understanding of that. It's going to have to, okay. It's not, can I do it right here? Okay. So you're going to have to stay with me because I don't think this is really working. Okay. Okay. So what I want to do is to talk through at a high level the process to achieve meaningful use. Next click. And as you know, there are a series of goals related to coordination of care and the quality of care that we're going to deliver. There are goals around interoperability that we need to achieve inside of this framework. But I want to move away from those objectives and really begin to focus on what is it going to mean for the practice of medicine. And I built a little cartoon that I think can bring those objectives to life, and I call this the meaningful use operating model, and how it's likely to play out in clinical environments all the way across the country. So if we focus on that in a little more detail, what we are going to see, and remember, the vast majority of medicine that's practiced in this country happens in small physician offices. Certainly groups of less than 25, and in many cases groups of less than 10, all the way across the country. So independent practitioners will be moving to the adoption of information technology and thinking about the meaningful use standards as their baseline. So in their office, they'll begin to see patients, do their note documentation online, manage the medications in a real-time way with alerting, and have access to clinical information to support their decision-making. Now, a lot of that information will be coming from other sources. So as they place their orders for particular tests, their patients will have those tests performed, and now the results of those tests will be available to them again in electronic form based on the assumption that interoperability will progress as we move through the meaningful use time period. Once they have that information, they will now be positioned to use the power of the technology to help them in their direct care of the patient. But I think equally as important that they will now be able to coordinate their care with other practitioners that are going to be involved in caring for complex patients. So this clearly implies that healthcare teams will most frequently be picked by the patients, and those individuals may or may not be part of the same organization over time. What's important to the patient is that all of the information is available to the clinicians that are part of their healthcare team that allow the best decisions to be made. Those tools then are shared between practitioners, and the information is shared from the ambulatory side to the inpatient side as well, and ultimately we close the loop with the patient going back to the practitioners that will be caring for them over the long run. So this is functionally what's going to happen as we move through meaningful use. What I wanted to move through is one example of transformation that can be built on top of that base assumption. So when I think about that, one example that I see large practitioners moving to right now, and I think can be a real concept for any practitioner once we're in the meaningful use state with interoperability, is the idea that we can start to rethink where care will occur. So with this technology, the idea of an office visit can be morphed to a care visit that could occur in the home, could occur in the employment setting for an individual, frankly could occur anywhere around the world. So here's one example of that that's beginning to play out and is totally predicated on the successful adoption of meaningful use and interoperability, and it's some work that we did at the Cleveland Clinic that we announced several weeks ago. So related to chronic care, as you know, this is this group of diagnoses where we spend the vast majority of our money today on health care. The idea that we can transform the delivery model from an episodic model, one where the patient goes in to see a physician on a periodic basis, even though they have a continuous disease that's with them every day, to a model that's far more continuous through the effective use of information technology. So here's a patient who may have diabetes or hypertension or heart failure, which are the three groups of patients that we worked with. The patient goes in to see their physician. Along with the normal conversation that they have in prescription, they now also prescribe some home technology that will help us with understanding the physiologic state of the patient when they're not sitting in front of the physician. So the example for that is shown here. These are basic tools: a blood pressure cuff, a scale, a glucometer, a peak flow meter, and a pulse oximeter. So when you're thinking about hypertensive diabetic patients or patients with heart failure, those are the consumer-friendly tools that will be with the patient anywhere they are, and those are rapidly becoming available. Now in the state of meaningful use, we have interoperability that's been accomplished, and that information can be collected and transported across the internet and ultimately make it back to the care provider who's going to deliver service for that patient. So all of a sudden, we've taken episodic care and we've moved it to a more continuous model of care moving forward. That physician can see, this is live at this point, that physician can see all of the information that's coming in from home, can use the power of the computer so that they don't become overwhelmed by the information, and it can be prioritized for them so that routine normal values aren't pushed to them every second of every day, but abnormal values get to them so that they can act on it. So the final loop of this is now it assumes that patients have access to real-time information as well. The personal health record is something that is also discussed in the meaningful use framework, and that physician now can act related to the information that they've been receiving. They can push that information back to the patient and actually begin to direct them in terms of what their next activities should be. Can you advance that for me? So what were the results of that process? So it fundamentally changed where the care delivery happened. If you think about hypertensive and diabetic patients, on average in this country, they come in physically to see their physician somewhere between 4 to 6 times over the course of a year. Because of the access to this information in real time, we were really able to reduce that to half the number of visits while managing their outcome measures, their actual blood pressure or their hemoglobin A1C to the same values or even lower for those given patients. The flip side was also true, and that is for heart failure patients, we were able to understand what was wrong with those patients in real time and actually move them to an ambulatory visit as a result of having this information rather than waiting until they were so ill that they ended up in an emergency room or ultimately being admitted to an intensive care unit. So from a care perspective, with meaningful use and a few more thoughts about how we can manage practice going forward, I fundamentally think we can transform the way and where care is delivered across the country. So with that, I want to turn the conversation over to Keith Michael, who's really going to focus in on what this means in the small physician's office. And he's going to take us through the challenges as we see them there. There is a delay.